GI is more predictable than any other step 1 or step 2 subject if you know what to look for. But most students don't. They memorize diseases instead of learning where pain localizes, what LFT patterns mean, and what triggers nausea. In part 2, I'm revealing more exclusive footage from our paid course showing how to think through GI physiology. These skills turn every abdominal vignette into a logic puzzle instead of a guessing game. Watch how thinking in physiology turns GI into free points. So I know that we've gone over this now 2 times, but I want to do it, or 1 time. But I want to do it again just because it's really important for what we're going to talk about. So I'll probably include this in the Google Doc so that you guys can see it. But I'm just going to have this here so you see again, LFTs, not tests of liver synthetic function, even though they're called liver function tests. So bilirubin, as a reminder, is a breakdown product of heme. Direct is conjugated, indirect is unconjugated, right? It explains a lot of the things like the color of poop and pee, also the color of bruises and other things. AST and ALT are basically, they're enzymes found within hepatocytes that are only released or mainly released if you have hepatocyte damage or death. So that's the main reason why AST and ALT are elevated. Alk-Phos is the main reason is actually because of an increase in synthesis, right? So this will become really important because we're going to talk about all of the LFTs and the patterns today. And because you'd think that if it was just because of leakage from damaged cells, that AST, ALT, and Alk-Phos would all be up in the equal amounts, but they're not. And it's because they're elevations for different reasons. AST and ALT are mainly because of damage. Alk-Phos is mainly seen in biliary stasis because of an increase in synthesis. Right? Obviously, AST, ALT, and Alk-Phos are found in other things that are not just hepatocytes. Alk-Phos is the one that you really should know about, although AST is also found in like muscle and stuff like that. But Alk-Phos is found in bone, liver, and placenta, among other things. And as a reminder, for acute liver failure, the most common ways of measuring synthetic function, there's a couple others other than PT and albumin, but the most common ones are PT and albumin. So acute liver failure, PT's up, albumin's normal, and then chronic liver failure, PT's up and albumin's low. That has to do with half-lives. So with that in mind, I want to go to our question. So a 25-year-old male has a 1-week history of fatigue and nausea with a 2-day history of skin yellowing. His past medical history is unremarkable. He denies any alcohol, tobacco, or illicit drug use. He works in a local restaurant. His temperature is 37.8, heart rate is 90, blood pressure is 115/78. Physical exam is significant for jaundice. His liver is slightly enlarged without tenderness. Abdominal exam demonstrates no spider angioma or fluid wave. What is the pathophysiologic chronology? So his labs, you can see, are bilirubin total is 6.2, direct bilirubin is 3.8, Alk-Phos is 200, AST is 1221, alanine aminotransfer, so ALT is 1349. PT and albumin are normal, and he's got positive anti-hepatitis A virus IgM, negative HIV IgG, and he's got anti-HBs antibody, which is positive, and then anti-hepatitis B core antibody, which is negative, and negative hepatitis B surface antigen. So I want you to walk through the pathophysiologic chronology. So let's go through the pathophysiologic chronology. So the summary would just be that he's got, from fecal-oral transmission, he's got an acute hepatitis A infection that leads to, we'll talk about the different patterns, but a very clear hepatocellular LFG pattern, sometimes called intrahepatic. So that's why because it's an acute infection, that's why it's IgM and not IgG. He's got inflammation of the liver, which we'll learn anytime you have inflammation of the liver or basically the gut tube or any of the derivatives, so liver, gallbladder, appendix, or pancreas, you can get nausea, just possibility of nausea. And so we'll talk about the detail later, but that's the big picture sort of summary of what's going on. So our summary of key concepts. So the main thing that we're going to go through today is to talk about the different patterns that you see for LFT abnormalities, because this comes up a lot. And so there is a more intuitive way of thinking about it, which is to think about it very similarly to how you think about like kidney failure. So you can think of it just like there's pre-renal, intrarenal, and post-renal. There's also, you can think about it for jaundice especially, you can think about it in terms of prehepatic, intrahepatic, and posthepatic. It doesn't work quite as well as it does with the kidneys, but it works like 90% of the time, which is pretty useful. It's a pretty intuitive way of thinking about it. I am going to include, however, the more common way of describing LFG abnormalities, which you'll see more in textbooks. And certainly that was what we learned at Stanford and what they did at MGH, which is thinking about it in terms of just recognizing the pattern. So isolated hyperbilirubinemia, which is kind of like the prehepatic, hepatocellular, which is essentially like the intrahepatic, and then cholestasis or cholestatic, which is basically your posthepatic. So there's a lot of overlap between them, which is why I included them in one. Sometimes you'll also see infiltrative, which I didn't include, but that's basically where you see just an increase in alphos and none of the others. So the other thing I want to talk about is a way of thinking, a systematic way of thinking about nausea and vomiting that is, I think, really helpful. Because when I was at your stage, it was really hard for me to think about nausea and vomiting because I was like, I don't know, like, can esophagitis give you nausea? What does that tell us? What does it mean? So the punchline is going to be that anytime you have obstruction or anytime you have inflammation of a gut tube or one of the four buds, so the pancreas, liver, appendix, or gallbladder, it can, not always, it can lead to nausea and or vomiting. Obvious caveats are that not all causes of nausea and vomiting are GI related. Right? You can obviously get GI. There are lots of causes of nausea and vomiting, which we're not going to talk about today. We're just going to focus on the GI causes. But it's useful to know what are the things that can cause nausea and vomiting from the GI. It's also important to note that the lack of nausea and vomiting does not rule out GI causes. Right? So if you don't have nausea, it doesn't mean you can rule out like hepatitis. That said, it is still a really useful way of thinking about nausea and vomiting. It's also really useful because you can use this as an analogy to think about coughing. Because again, I always had a really hard time of thinking like, what would cause coughing? What's a good systematic way of thinking about coughing? And so in the same way that obstruction or ultimately pressure or inflammation of the gut tube or its derivatives can cause nausea and vomiting, basically the same thing in the respiratory tract can cause coughing, right? If you increase pressure on the wall of the respiratory tract, so a bronchoscope, something where you're looking into someone's lungs and you brush the side of the wall, they will cough like crazy. I can tell you that. Personal experience. And inflammation, also the same thing, right? Like, why do viral illnesses cause so much coughing? Asthma. Why do steroids help with reducing coughing, right? It's basically the same idea. All right, and with that, we will get started. If you're serious about maximizing your scores, join our 14-day mini course now. We'll send you 14 high-yield videos that break down the exact concepts and test strategies our students use for 260 plus scores. Click the link in the description below now to get instant access. All right, so our systematic approach. So as a reminder, there are two most common causes of approaches for LFT abnormalities and for jaundice. So again, the most common is to look at just the pattern recognition. So you'll see hepatocellular, isolated hyperbilirubinemia, cholestatic, and then sometimes invasive. It's essentially high alk phos, but everything else is close to normal, including the bilirubin. So it's sometimes included, so I describe it just so that you know, but it's not that common. So bilirubin, the more intuitive way of thinking about it is to look at causes of jaundice. So causes of jaundice, one schema is to say prehepatic, intrahepatic, or posthepatic. So they're essentially interchangeable. And so in the hospital, you'll probably hear this more often, but in your head, oftentimes I think it's actually more useful to think about in terms of pre and post. But I included both so that you can rock both the intuition as well as rounds. So let's go to Paula. So Paula, prehepatic versus intrahepatic versus posthepatic. So using your knowledge of bilirubin, explain which would have the highest direct conjugated bilirubin and which would have the least, if it was pre, intra, or post.
The highest conjugated posthepatic.
Perfect. Yeah, exactly. And why does that make sense?
Because when we're talking about posthepatic, we are saying cholestatic. So then if we have a problem, if the problem is not in the liver, so we're going to be able to conjugate the bilirubin. So from indirect to direct.
Exactly. Yeah. Great. So posthepatic is going to have the most. Sorry, I shouldn't show it to you. So which is going to have the least?
Then it's going to be the prehepatic.
Good.
Yeah.
Yeah. So post, right? Because the liver is fine in posthepatic, right? So you can conjugate just fine. The problem is that the conjugated bilirubin, for whatever reason, cannot make it into your GI tract. So there's cholestasis, right? So that would have the highest conjugated bilirubin. Intrahepatic is going to be in the middle. So you're in the process of conjugating it. So you're conjugating some of it, but because of damage to the liver cells themselves, you're going to have spillage of bilirubin from inside the hepatocytes. The prehepatic, there's the least direct bilirubin. You are increasing the production of unconjugated bilirubin in most of these cases. The other cases of isolated hyperbilirubinemia would be like what we saw before with Gilbert, where the problem is that you just can't conjugate it. This is why it's not quite as perfect of a schema as it is to say pre-renal, intrarenal, post-renal, because it gets a little messy to say like prehepatic for things where it's a problem with conjugation. It's a problem with the liver, but it looks like the prehepatic. So that's why I think it's probably not quite as common, because it will not cover 100% of the situations. It is more intuitive though, which is why I included it. So hepatic versus intrahepatic versus posthepatic jaundice. So using your knowledge of bilirubin, explain which would have the darkest urine and which would be the least dark. All right, we'll move to Matan. So Matan, what do you think?
So we look at the solubility or the polarity of the molecules. So direct bilirubin is polar, therefore it's not bound to albumin, it's freely filtered, it'll end up in urine, urine will be dark. Unconjugated or indirect is non-polar, it's bound to albumin, not freely filtered, it won't darken the urine.
Boom. Yeah, exactly. So in other words, the posthepatic is going to have the darkest urine. Absolutely. And it's for exactly the reasons that you said, because the direct bilirubin will be soluble in the water. And so it can actually enter the urine. And so that's why posthepatic is going to have the darkest urine. Intrahepatic, again, is going to have the middle. It's sort of like Goldilocks. It's going to have the middle amount of conjugated bilirubin. So it's going to have maybe a little bit of dark urine, but not too much. And then the prehepatic is going to be mainly unconjugated bilirubin. So less than 20% of it's going to be conjugated. And so that is going to be largely not dark urine. It is almost never dark. Great, or at least from the bilirubin itself. All right, so Joni, so using your knowledge of AST and ALT, which would have the highest levels?
So AST and ALT are indicative of intrahepatic. Would it be?
Yeah, great. Yeah, so the highest in intrahepatic. Great. And why?
It's AST and ALT are indicators of hepatocellular damage.
Yeah, they're enzymes that are found within hepatocytes. If you have damage to the hepatocytes, they'll be high. Great. And so great. Exactly. So posthepatic might have a mild elevation, right? Oftentimes you'll have a little bit, which is why I think people get confused, because there will still be some elevation even in posthepatic, presumably because you still get some damage from cholestasis if you get backup of bile, although it's not nearly as much as it is in intrahepatic. So prehepatic has virtually no elevation. So the reason why it's called isolated hyperbilirubinemia is because that's basically all you see. All you see is the increase in bilirubin that is indirect. All right, Grace. So using your knowledge of ALK-Phos, which would have the highest levels?
So would it be posthepatic?
Yeah.
See, I know that increased ALP is associated with cholestasis. I'm trying to remember.
Yeah, it's not super important to remember why. There is an increase in synthesis, right?
Right.
So the reason is because of an increase in synthesis. The reason why I include that, as opposed to just memorizing it, is because it helps explain why because it is actually an enzyme that is found within hepatocytes. So you would think that if you damage hepatocytes directly, that ALK-Phos should increase the same amount as AST and ALT. But the reason why it's not is because the major reason why ALK-Phos goes up is because of an increase in making of ALK-Phos. And that happens for whatever reasons that are unclear to me, when you have cholestasis. So it's interesting. It's not, at least in the papers that I read, we don't know what ALK-Phos does in what the major purpose is in the GI tract. So there is a small elevation, right? So it's the opposite of the AST and ALT, right? So for hepatocellular, you have a lot of AST and ALT and a little bit of ALK-Phos. For the posthepatic or cholestasis, you'll have a lot of ALK-Phos and a little bit of AST. A lot of ALK-Phos, a little bit of AST, ALT. So prehepatic, again, it's isolated hyperbilirubinemia. You don't really see much of any of the ALK-Phos. So sometimes you will see something called R factor. So let me tell you what R factor is. I don't think that it's one of those things that you should memorize. I think the concept is more valuable. So I want to talk about this. It was actually in the white book for MGH for like the interns that talk about like LFT abnormality. So it is used sometimes, but I think the concept is probably more valuable because I think people still get really confused about like how to recognize these patterns. So R factor in the equation is ALT over ULN, which is the upper limit of normal. Sometimes you'll see ULN. So ALT over the upper limit of normal divided by ALK-Phos over the upper limit of normal of ALK-Phos. So the major downside to this, because you may be wondering, because you'll see ULN sometimes, like for example, in like Light's criteria or the Light criteria, you'll see upper limit of normal for looking at total protein, or no, albumin. I think it's albumin. And so you might wonder why is this not a fixed number? It's because the upper limit of normal varies by the hospital. So I looked up what the upper limit of normal was for the USMLEs. So for ALK-Phos, it's 70, and for ALT, it's 20. So if you do the math, right, if you flip this around, right, so the upper limit of normal, right, so you're dividing by something you're dividing by. So if you flip this, right, the upper limit of normal of ALK-Phos and do the math, right? So the upper limit of normal of ALK-Phos ends up on top and the upper limit of normal of ALT ends up on the bottom. And so if you look at the ratio of these, it ends up being 3.5 for the USMLEs. Again, for your particular hospital, it will be different, but for the USMLEs, I did the math and it's 3.5. So what would be then, if you followed this, and then I don't think I did a very good job of explaining this, so probably couldn't follow this, but we'll see. Sujith, what would be a quick and dirty way to calculate the R factor? Right? So ALT over the upper limit of normal divided by alk-phos over the upper limit of normal. So what would be a quick and dirty way to calculate it? And what does it tell you?
ALT by ALP.
So it would be, so R factor is ALT divided by ALP times 3.5. So in other words, all of this times 3.5. Right? So this is written with the correct order of operations, but I just want to make this really clear. So in other words, if R is above 5, that tells you that it's hepatocellular. If R is less than 2, that tells you that it's cholestatic. And so again, this quick and dirty way really is only like USMLE specific. It will vary depending on the hospital. I have some examples of this. So I want to show you how you can use this and why it's valuable. The reason why I am even bringing up R factor in the first place is because just to say, because you'll see tables like this where it's, what's most prominent? So AST is most prominent in the intrahepatic. Alk-phos is most prominent in posthepatic. If that's with you, you don't really have to worry about R factor. It's more when they're both elevated and you're like, gosh, I don't know. What's more elevated than normal? Geez, I don't know which is most prominent. That's where R factor comes in. And also to tell you what's mixed, because if it's between 2 and 5, that tells you that it's a mixed pattern. So Sujith, let's say that the ALT was 900 and the alk-phos was about 300. What kind of LFT pattern would this be and why? Those were the only two things you knew. Could you calculate the R factor and tell me what the LFT pattern would be?
It will be, are you asking if it's hepatocellular or pre-hepatic? This is hepatocellular.
Great. And how did you come to that?
It's more than 3.5. So 3 into 3.5 is around 10.
Great. Yeah, perfect. Exactly. So you can do it one of two ways, right? You could do it like Sujith said, where you like eyeball the R factor and see is it 5 or less than 2. That was the point of this question. But if you are comfortable just saying, well, ALT is like really high, alk-phos is just like a little high, that's also okay. Honestly, that's how normally I go about this. It's just that that's a lot harder to communicate to someone else. It's a lot harder to teach someone. Say, just like eyeball it and say, alk-phos is a lot higher than normal, or ALT is a lot higher than normal, and alk-phos is just a little bit higher than normal. That I think is harder to do, especially if you don't have a lot of experience looking at LFTs. So if you're not comfortable with that way, then R factor is for you. So you can think about it as the elevation of the ALT is much more prominent, but to be more precise, you can do what you just did, which is to say ALT over alk-phos is about 3, right? And so 3 times 3.5. So this is USMLE specific, 3.5. It's about 10. So that's a lot more than 5. So this would be hepatocellular. Cool. All right. So we are going to practice this more. Do you want to take a shot? Oopsies. Want to take a shot at this? So what pattern of LFT abnormalities is this? And what condition is most likely?
Would we first look at, I guess, the ALT? So that is going to be 1349. And then I guess that would be high. And so with the ALP at 200, so let me do that real quick. And then multiply that by 3.5, right? So 23, which is greater than 5. And so that would signal me towards an intrahepatic.
Perfect. Yeah,
Okay.
exactly. Yeah.
Cool.
So I think that's the easiest. So again, so the other way of doing it would be to say what?
The other way would just be like looking at ALT is much, much higher than ALP.
Yeah, or just to say, yeah, exactly. Or just elevated over normal is much higher than the amount that alk-phos is elevated over normal.
What was the normal value again for the two?
I think 70 is alk-phos. Upper limit is so alk-phos. The thing to remember is alk-phos is a bit higher than ALT. So I think it's 70
Okay.
for alk-phos and then 20 for the USMLEs for.
Okay, yeah. That's a part that I wasn't familiar with. But yeah, that calculation is actually like much more straightforward for me. So that's cool.
Good. Again, I include both just to give you guys like a sense. I should be completely upfront with you. I don't use R factor. I just eyeball it and say, man, this is a lot higher than, this is like real high. This is, a little high.
Right. Having that frame of reference for sure. But having the equation to calculate it out for me like that, it was a lot easier.
And I figured, it was good. In fairness,
Cool.
The other thing is that you can also use the percentage of the bilirubin, right? So the direct bilirubin is a little less than 50%. So that's also very characteristic of an intrahepatic or hepatocellular pattern.
For sure.
Cool. So I included all of these so that you can be really clear. And again, let's be honest. It's patients, the real world, even the tests, they're not going to have necessarily read these textbooks. Like sometimes maybe the direct bilirubin is going to be more than 50%, a little bit more than 50%, or that's like the major one. Sometimes like this doesn't fit quite as perfectly as you want it to, but go with the thing where most of it's going to make sense.
Right. I think honestly, like when doing like practice questions and using this approach, it'll help the application part of it be a lot easier.
I think so. And so again, this is why the IgM is positive, but there's no IgG because it's an acute infection. All right, so Saba, how about this? So walk us through. So again, I want you to use as many of the different, because we want to practice this. For these purposes, I want you to use as many of the different ways of determining what LFT patterns it is. Yeah, so go for it. I've only given you one, I guess. Saba, are you there? You have to remember to unmute yourself.
Oh, sorry. Yes. So in this case, because the indirect bilirubin, which I calculated from total bilirubin minus direct bilirubin, that would be 5. Because the unconjugated bilirubin is higher, that would make me think that it's a pre-hepatic.
Perfect.
Because, yeah, if you haven't made it to the liver to get conjugated yet, then, yeah, you wouldn't expect.
Now look at the other labs, because again, I gave you a ton of clues here that they weren't AST, ALT, ALPHOS, but I gave you a ton of clues. So why is there an isolated hyperbilirubinemia in this case? I'm looking specifically at the hemoglobin and the direct Coombs test. You may not have been here last week.
No, I wasn't, unfortunately.
Okay, that's okay. So I'll pick on someone else. Zach, you're taking your test real soon, so let me hear it.
All right, so direct Coombs test. So you have second autoimmune reaction. You have antibodies against RBCs. They break down the RBCs. They break down the RBCs. And in intravascular, like hemolytic anemias, your indirect bilirubin is going to be high, and your hemoglobin is obviously going to be low. So you're shredding RBCs.
So interestingly enough, intrahepatic, actually extrahepatic is more associated with high bilirubin.
Did I say intrahepatic? I meant to say intravascular. My bad.
And that's because, and let's be clear. So the reason is because if you have intravascular hemolysis, if you have shearing from DIC or HUS or something like that.
Oh, okay, yeah.
You don't have, the hemoglobin is free floating.
Yeah,
it hasn't had time, the macrophages haven't had time to just consume it, turn it into bilirubin.
Yeah. So should I rephrase this as like when you have an autoimmune hemolytic anemia, then your indirect bilirubin is going to be high?
Yes. Yeah, exactly. Yeah. Perfect. Because what question are you answering? What is that?
So like why is,
What question exactly are you answering with the direct Coombs test?
So you're answering, do you have antibodies against the RBCs? Is that what you mean?
Yeah.
Or antibodies against
the question is, did immune-mediated hemolysis happen already?
Okay, yeah.
Versus the indirect is basically saying, could you have
potentially have it if you added RBCs?
Like, do you have antibodies that could cause?
Yeah, this is like what we did last week.
Yeah, exactly. Perfect. Yeah, exactly. So that's why. So in other words, so you've got autoimmune hemolytic anemia, right? And so the pattern is, pre-hepatic, right? So isolated hyperbilirubinemia. So and the way that you can tell is that there's the D-bili is low, and I didn't include the LFTs, but the other ones would have been normal. And so again, the direct Coombs is telling you the RBCs are already coated with antibodies. In other words, the question that you're asking is, did hemolysis already happen?
Yeah.
Perfect. All right. So let's go to Mary next. So Mary, what pattern of LFT abnormalities is this? And what condition is most likely? All right, we'll go to Deb. Deb, what do you think?
So there's elevated alkaline phosphatase, and so the ratio of ALT to alkaline phosphatase is less than 2, and so this is a post-hepatic pattern.
Great. What else can you use to help? Okay, so that's good, right? So you said alphos is really high, ALT is not that high. And if you were to do the R factor, then it's less than 2, so great. So that would be post-hepatic. What else can you look at to argue that this is post-hepatic?
The direct bilirubin is high.
Yeah, exactly. It's mainly direct bilirubin. Great. And if you want to quantify it, it's 80%, much more than 50%. Great. What condition is this? Now we got to put it together, right? So there's 2 parts to lab analysis, right? Like you got to say, what's the pattern, right? But you also have to look at the bigger picture and say, what exactly is going on?
There's leukocytosis, and the CBD is dilated. Is there any cholelithiasis or?
Yes, there is. Where is the stone? Where is the stone located? And why is the leukocyte high?
The CBD is dilated, so the obstruction site, is it cystic duct or CBD?
Yeah, it's got to be the CBD, because if it's in the cystic duct, your common bile duct should not be dilated. Why is the leukocyte count high? Why is the white count high? It's pretty high. 22,000 is high.
There's a leukemioid reaction due to infection or inflammation.
It's very good. Exactly. Yeah. So this, I was trying to show cholangitis. Yeah. That would be the easiest way to look at, to explain all of these things. You've got really high alk phos, mild elevation of the AST/ALT, and really high D-bili relative to the total bilirubin. Your white count is really high and you've got a dilated common bile duct. This would be very concerning for ascending cholangitis. So your direct bilirubin would be, yeah, so we talked about this. So the pathophysiology, just to be very clear, so you've got gallstone from the gallbladder that lodges in the common bile duct. So the common bile duct pressure is going to increase for whatever reason, probably because of pressure ischemia. You will have bacterial translocation, right? Because there's bacteria that's just present in the lumen. So they can infect the wall. And as they infect the wall, that infection can ascend. So that's how you get cholangitis. That's the basic idea of getting cholangitis. So the bacteria, it's really easy then to enter the bloodstream. And so that's why you can get such a profound leukocytosis. So this would be pretty scary, pretty severe, or potentially pretty severe. Questions so far? So we just covered the LFT patterns and did some practice, as well as giving you various different ways of thinking of differentiating between the different kind of patterns. Questions so far before we talk about nausea, vomiting, and then make an analogy?
Alec,
Yeah.
it's Metan here. On the slide before, so is that actually heading towards renal splanted where you get the hypertension and the altered mental status because you're basically almost in septic shock?
Yes. Oh yeah, exactly. I think that is why. Yeah.
Cool.
I think that's why you get, yeah, because it's basically, it's basically septic shock. Yeah, you hyperperfuse your brain, and so you can get.
It's nice. I never knew why. I always knew that it happens, but it's nice to connect the dots.
Yeah.
Cool. Thanks. Yeah.
I have a question, Alec. Would your PT be elevated in that last scenario if it was like really bad and the white count's not like insanely high? It's not like 70,000, but could your PT be,
I guess though, probably not though. No, probably not. Could it happen? Sure, absolutely. Yeah, but I don't, because you'd have to say that there's a liver failure. Is there a liver failure? I mean, it could, in theory, sure. Any infection, any form of septic shock could, in theory, give you liver failure. So if you showed me a picture where like the PT was elevated, could I see a conceivable mechanism how they could have had liver failure? Absolutely. But could you rule out ascending cholangitis because their liver synthetic function is normal? No. Does that make sense?
Yeah, thank you.
Yeah, great question. Fantastic question. All right, other questions?
Sorry about that. It's a question about septic shock one. The reason why we said septic shock, is it because of increased leukocyte count?
Oh, sorry. You caught me. Technically, septic shock is, so the definition of septic shock is actually that you've given enough fluids and they still don't respond to fluids and you need pressors.
Right.
So we don't actually know that they have septic shock here. So I guess technically what I think Matan and I should have said is to say that shock, in other words, insufficient perfusion of your end organs, which is the organ we care about is your brain, right? If you're trying to describe why someone with sepsis could have like encephalopathy or altered mental status, shock could explain why you have altered mental status. But technically, based on these labs, you do not know if this is septic shock, right? Technically, you'd have to say like severe sepsis.
Correct. Yeah.
I like it. Yeah. Gotta keep me honest. Precision
Sorry,
with
I'm sorry.
language. Thank you. No, that was really good. Matan?
Thanks.
Yeah, absolutely.
Alec, what's the reason that bilirubin or hyperbilirubinemia causes pruritus?
Oh, interesting. So it's not that bilirubin, my understanding is it's not the bilirubin itself that causes, it's a correlation, right? It's BUN increased. People that have high BUN can get like uremia. It's not because the BUN itself, it just correlates with it. I think the same thing is true with bilirubin. My understanding, the way that it was explained to me is that it's because of the bile salts, right? So bile salts emulsify fat, right? So they help basically dissolve and increase the surface area of fat. So that can get into your skin, into your fat. So my understanding is that the pruritus comes from the bile salts itself, not bilirubin. Yeah. All right. So let's talk about some nausea and vomiting, right? The punchline is going to be that nausea and vomiting for the GI tract and cough for the respiratory tract are both confusing, but at least there is an intuitive way of thinking about it. There's a sort of a systematic way of thinking about it. And before we do that, we're going to talk about the gut tube. Zach, what are the derivatives of the gut tube?
Yeah, so derivatives of the gut tube comes from endoderm. So you're going to have your pancreas, liver, appendix, and stomach.
What else?
And then your intestines. So small intestine, large intestine. Yeah.
Perfect. Yeah, basically everything from like your esophagus all the way
Downwards,
down,
yeah.
like
Sorry, those are the gut buds, right?
exactly. Yeah.
Yeah.
The systematic way of thinking about it is like your entire GI tract from your esophagus all the way to the upper part of your anal canal, right? That entire length
Yeah.
of bowel esophagus. Plus the 4 buds that attach to the GI tract, the bud
Yeah.
off bit, pancreas, liver, gallbladder, appendix. Great. And so Feluke, can obstruction of the gut tube or its buds cause nausea/vomiting, and why?
Yes, it can, since there's going to be pressure.
Yeah, exactly. So there are mechanoreceptors, right, that sense pressure, as you said, in the GI tract wall. This forms the afferent signal to the vomiting center in the brain.
Alec, I have a question.
Please.
Is there a serotonin associated with this? Because I was just doing a UWorld question about how you give on like a serotonin blocker for anything that causes like irritation.
I think it's actually, so like ondansetron, I think is actually a central mechanism.
Oh, okay.
Yeah, the
All right, just
H3,
curious.
I'm pretty sure is a central mechanism. I'm pretty sure
All right.
serotonin is not involved in the afferent signaling. I could be wrong.
All right.
But I'm pretty sure that's a central mechanism. Because again,
All right.
the reason why I say that is because ondansetron works for things that aren't just GI related. So like postoperative nausea and vomiting, that's like the most common drug is to give Zofran.
Oh, I see. All right.
Good question. But again, this is why it's confusing. So what I'm trying to do with this nausea vomiting portion is to elucidate one aspect of a very confusing topic. Right? Nausea vomiting is very confusing. Like many things can give you nausea and vomiting. I'm not trying to explain everything that can cause nausea and vomiting. I'm trying to explain the things, like a systematic way of thinking about the GI causes of nausea and vomiting. So to hopefully make it more attractable. So Vi, what effect generally does inflammation have on nerve excitability?
Inflammation, doesn't it increase the excitability?
Yeah, it does. Yeah. So I went really deep down this rabbit hole, but I can tell you, I can summarize it basically by saying that inflammation generally causes both the nerves and the nerve receptors to be sensitized. So again, that's a huge field of research. I was shocked at how many papers and things, like stretching back decades. But generally, this is true. So if you are interested, some of the more representative findings would be prostaglandins increase mechanoreceptor sensitivity. Inflammation also causes an increase in sensitization of nociceptors. There was also these really interesting studies where they looked at why inflammation can cause nerves themselves to become sensitized. Like nerves generally don't respond that well to touch. They don't respond that much to like touch. However, in inflammation, they do, and there's like interesting mechanisms for why. But the general way for your stage in general, right? I think the best way to think about this is that inflammation causes nerves and nerve receptors to become more sensitive. Leah, in the GI tract, what effect does inflammation seem to have on nerve excitability? How can you use this to explain the symptoms of things like inflammatory bowel disease, like Crohn's or UC?
Okay, so if we're saying that inflammation increases the nerve excitability in the GI tract, then in something like Crohn's, that's a chronic inflammatory state. So you're like chronically having the vagal afferent nerves in the GI tract like constantly stimulated. And so you're going to get like probably nausea and cramping and that sort of thing.
Yeah, nausea, cramping, diarrhea. So inflammation leads to sensitization to distension, right? There's a number of papers on this. If you want to look at the PubMed IDs, this is what they are. So the thought, I didn't really know this, but the thought for why like IBD happens, or one of the thoughts for like why the symptoms of IBD happen, is that you get chronic inflammation. So that causes you to become more sensitive to distension. So remember, distension is the signal for the gut to move things through, right? So that's why you give like bulking agents. That's why fiber, right, makes you have to go to the bathroom. It's because you can't digest, well, it's insoluble fiber, right? You can't digest insoluble fiber and it's bulky. And so it distends your gut, and your gut senses the distension, and it causes contraction of the GI tract and causes the peristalsis. And so one of the very common symptoms of IBD and inflammation of the gut in general is tenesmus, right? The feeling like you have to poop, but you're not able to, like, you still have to poop, but like nothing's coming out. And then another symptom that's really common is diarrhea. And so a really tantalizing explanation for that is to just say inflammation sensitizing the gut to distension, which that is true. That seems to be pretty well established. So inflammation sensitizes the gut to distension, presumably because of increase in mechanoreceptors or increase in sensitivity. And so that would explain both why it feels like you always have to go or that you will go but you still can't get everything out, right? Because you're really sensitive to any sort of pressure, and why you get diarrhea. Because again, even just a little bit is going to cause you to feel like there's a lot there, which is going to cause your bowels to move quickly. Kind of cool. Yeah. This is also, as I went down the rabbit hole, hypothesized to play at least a role in things like irritable bowel syndrome. Right. So irritable bowel syndrome. So it is established that 90% of people with IBS have heightened sensitivity to mechanical distension of the bowel. So one of the most tantalizing explanations for why, and at least it explains it in some, it would explain in some of the cases, is that you get an inflammation or infection or something. So that will sensitize you to distension. And for unclear reasons, some people seem to be more likely to have persistence of that sensitization, even when the inflammation is stopped, which is why they have to run to the bathroom so much, right? It's irritable bowel is like the equivalent of urgency for the urinary system, right? Which again, very similar idea. So if you've got inflammation of the bladder, you will have sensitization of the bladder to mechanical distension, right? So normally you have to distend your bladder a fair amount to feel like you need to pee. If you have inflammation of your bladder, even just a little bit of distension is enough to now make you think that you really have to pee and to set off the micturition reflexes. So again, my goal with this lesson was basically to try to give you general principles for thinking about these very common clinical phenomena and to try to help you to see the connections between them in a way that wasn't just you have to memorize it, which is why you see all these links to articles and PubMed IDs and stuff. Because I wanted to make sure that this was reasonably well established. Okay, questions so far?
Alec, can I go back to my point about serotonin? I don't mean to be a know-it-all about this. This is just literally the last question I did before our class started. So I found the UWorld explanation. Can I just read it out and we can make sense of it then? Like
Sure.
the line.
Yeah.
Yes, one line. Yeah, so conditions that cause BI irritation, example, infection, chemo, distension, result in increased mucosal serotonin release and activation of 5-HT3 receptors on vagal and spinal afferents. And then these then relate their impulses to the medullary vomiting center, inducing emesis. So is there? Yeah, so like I literally just did this question before class started, which is why it was like preying on my mind. So it seems as if there's like mucosal serotonin released. Yeah.
Sure.
And then, yeah, so that's, yeah. And that's like, so the distension causes mucosal serotonin release, which hits 5-HT3 receptors. I think, yeah. I can copy the explanation.
Yeah, let me see. I don't want to, I don't know. The short,
I don't want to disrupt your flow or anything.
The honest answer is I don't know. It would be cool. I would love for that to be true, but I think I'd have to look into it more.
Yeah, you can look over it later.
Yeah. That's cool. No, I love the connection. So Ghana. So tenesmus. So again, tenesmus is the feeling of incomplete emptying when you're trying to poop. To use the proposed mechanism to explain why, like how the patient feels.
We're talking about how like when you have inflammation and it causes increased stimulation, it can cause tenesmus.
Yeah, exactly. Why would that make sense?
I guess that because if like the bowels or whatnot are moving too much, that you can't properly empty what's the word I'm looking for? You can't like properly get rid of all the poop.
So I don't know that it's so much. So maybe there is some effect of like you can't get rid of all the poop. Oftentimes, though, I think that you don't have to invoke that. Remember that with inflammation, you get sensitization of the nerves, especially to rectal distension. So even if, right, so normally you have to have a fair amount of stool in your rectum to feel like it's distended. If you had inflammation, do you think you would need more distension or less distension to feel the same degree of fullness?
Oh, you need
less distension. Yeah, exactly. So if you had enough inflammation, even if you didn't really have much there, it might feel like there was a lot there. Does that make sense?
Yeah, that makes sense.
So that would explain, because I'd always memorized that inflammation causes tenesmus. You typically see that in something like UC or Crohn's, but you don't have to, right? And then I looked a little bit further and I was like, oh, actually, you typically see it in inflammatory bowel conditions. I was like, oh, so I can memorize that. But really, you don't have to memorize that. It actually makes total sense. Cool.
Yeah.
All right, so Moe, so can inflammation of the gut tube or its buzz cause nausea/vomiting? And why would that make sense? All right, we'll go to Paula. Paula, what do you think?
We're going to use the same theory that we have been using. Since we have inflammation, then we're going to have sensitization of the nerve. And this is going to cause for the person to feel bloated and to feel distension. And then this is going to cause nausea.
Yeah, exactly. Yeah, because you're sensitizing all the nerves. So now a little bit of pressure is going to go a long way. Even though it's a little bit of pressure, your gut's going to think it's a ton of pressure. And so now it's going to think, oh gosh, there's some obstruction. We need to get this out. And you're going to feel nauseous.
Perfect.
Logic.
Thank you.
Yeah, that's cool. Nice. So Matan, so what is a good way to think about the GI causes? So let's sum it up. So the GI causes of nausea, vomiting. It's a good sort of general way.
So, causes of inflammation.
Yeah.
Sorry.
Inflammation or what else?
Obstruction.
Yeah, obstruction. Yeah. Basically, anything in the gut tube or its four buds that causes obstruction, so increasing pressure, inflammation, in other words, increased sensitivity to, or a toxin, right? You got to throw that in there. It's the GI tract. But yeah, basically obstruction, inflammation, or a toxin, which is cool. I remember the reason I came upon this was because I was looking at my daughter was just kept vomiting. She was 4 or 5 at the time. And I was like a typical like doctor parent. I was like, let's figure this out. What's going on? Do I need to take her to the urgent care? So I was looking, I was like, oh wow, this is actually a really good way to think, really great way, some like random paper. It's a really good way to think about nausea vomiting, right? And that was basically what they said, obstruction or inflammation. I had the toxin thing. All right, Joni. So can appendicitis cause nausea and or vomiting?
Yeah, it's the same mechanism. Right?
Yeah, same mechanism, right? Hepatitis. Yeah, Grace, what do you think? Grace, can hepatitis cause nausea and or vomiting?
Yes, also the same mechanism.
Yeah, same mechanism. Again, this is what I'm building towards because it was always really confusing to me. What, gosh, can hepatitis give us nausea, vomiting? Can esophagitis give us nausea, vomiting? Can pancreatitis give us nausea? I don't know. Right? Now it's pretty clear. You can, and you've got a mechanism for why. So, Sujith, if you do not have nausea, can you say this is definitely not? No, unfortunately. It'd be so nice, right? That'd be so nice. If you could just, if there was something that was that sensitive, it was that sensitive, but no. The absence of evidence does not mean the evidence of absence. So unfortunately, no. Sue, so is all nausea, vomiting caused by GI tract mechanoreceptors? Can you tie every cause to this mechanism? No, unfortunately. That'd be nice. That'd be super nice, but no, you can't. Yeah. However, I still think it's important to think about because again, a lot of the causes, particularly the causes that you're going to see on your test, and honestly in real life too, are going to be GI related. And when someone comes in with nausea, vomiting, the first thing that everyone's going to think about is GI, whether it's true or not, it's GI. So it's a good way to schematize it in your head to know how to approach it. All right, so now we're going to tie this to coughing. So Saba, I'm going to make you an analogy, Saba. So nausea and vomiting is to the GI tract like coughing is to the respiratory tract. Right? So Saba, what's a good way generally to think about coughing and the respiratory causes?
I guess with the same concept of increased sensitization.
Yeah. So if inflammation or increase in pressure causes an increase in nausea and vomiting in the GI tract, what would cause an increase in coughing in the respiratory tract?
I'm sorry, my connection was in and out. Could you please repeat that really quickly? Sorry.
Yeah, absolutely. So we're saying that inflammation or pressure cause an increase in nausea in the GI tract. Would it be fair to say that an increase in inflammation or pressure in the respiratory tract could cause an increase in coughing?
Yes.
Yeah, for basically the same mechanisms. If nausea and vomiting is caused by obstruction or inflammation of the gut tube or its buds, then coughing is basically caused by pressure or inflammation in the respiratory tract, trachea, or airways, or alveoli. So let's think about it. This comes up a lot. So Deb, what are the 3 most common causes of chronic cough in a non-smoker? So smoking obviously causes you to cough. You got, I guess, inflammation, maybe a little bit of pressure too, but definitely inflammation. So Deb, what are the 3 most common causes? Do you happen to know?
Postnasal drip.
It's pretty good, actually. GERD is the 3rd. So postnasal drip, asthma, and GERD. Great. This is one of the things that you should know because they're going to, especially for step 2, they're going to give you someone that comes in with a chronic cough that's not a smoker, and then they're going to describe to you basically, do they have GERD symptoms or not? Do they have asthma symptoms or not? Do they have postnasal drip symptoms? It's also a pretty common presentation in primary care clinics. So Zach, so bronchoscopy, right? So this is a bronchoscope, right? You stick a little fiber optic thing into their airways and you're trying to look at the different airways and get stuff from their lungs. So if you touch the side of the trachea or the bronchi with a bronchoscope, if I am snaking this in and I go boom, and I bash the side of or just lightly touch the side of the trachea, what's the patient going to do and why?
Start coughing and gagging because you put pressure.
Exactly.
And so kind of mimics obstruction.
Yeah, again, it's not really, so it's obstruction in the GI tract. It's not really like,
you said pressure and space.
You have a much lower threshold because normally there's supposed to be stuff in the GI tract. So it makes sense that you need a lot of pressure to get to the point.
So it's kind of relative,
Yeah, there's not supposed to be anything in your respiratory tract.
Yeah.
Even just a little bit. Yeah, so they cough like crazy. I can tell you this. Yeah, having done anesthesia, it's, really, really, unless you deeply anesthetize someone, You just brush the side of the airway. They cough like crazy. So GERD, can this cause coughing and why?
Yes, it can cause coughing because you have pressure, you have irritation and inflammation.
Perfect. Yeah. So it's causing inflammation of the airways. Great. So you can sensitize the mechanoreceptors, so you will cough more. Great. All right. So Vi, so asthma, can this cause coughing and why?
Yes, because you have inflammation of the small airways.
Perfect. Yeah, exactly. Yeah. What's interesting is that there was I think it was like a NEGEN paper not too long ago where they looked at like the difference between like inflammatory and non-inflammatory asthma and to see who responded better to steroids. And it's, answer, but inflammatory asthma responds much better to steroids, as you can imagine, presumably for this exact reason, or at least partially this reason. So yeah, you get inflammation of the airways, so you presumably you're sensitizing the mechanoreceptors, and so you'll increase your coughing. Great. Leah, so postnasal drip, can this cause coughing and why?
Yeah, a similar reason. You have the postnasal drips going down your throat and it's irritating. And so you're, again, similar sensitization going on, and then you're going to cough.
Yeah. In this case, too, I think you also have the mechanical effect of like you have mucus. There's like stuff there. So presumably that's going to cause coughing too. But yeah, I assume there's some inflammatory component as well. So Agana, what would be the likely etiologic mechanism of a dry cough? Because you see this a lot. And like when I was a medical student, it never made sense to me, like dry cough, wet cough. Why productive cough? Like, why does that matter?
I think it matters because with the productive cough, you have an over secretion of like the glands, which causes like the mucus to stay and you have to cough it up. I feel like a dry cough, there's some kind of irritant, but it doesn't cause like mucus to be built up.
Yeah, exactly. Either because of inflammation or because whatever that is there can't be easily coughed up.
Yeah.
But the more likely thing, usually it's because of just inflammation, right? It's often inflammatory, which again would make sense if you sensitize the mechanoreceptors. That's why even just like a gust of cold air can cause you to have bronchospasm if you're an asthmatic. All right, so I want you guys to update your pathophysiologic chronologies and we will talk about it. So what I'm going to do is, again, so instead of just reading it, I'm going to actually read it and analyze it as if I was going to do it myself. So got a young guy, has a 1-week history of fatigue and nausea with 2 days of yellow skin. So he's got jaundice for 2 days. So a week ago, he started to having fatigue and nausea. So vague symptom, although probably more GI. And now you've got some skin yellowing. So you're thinking already GI, either obstruction or inflammation. His past medical history is unremarkable. So healthy guy, no bad habit. He works in a restaurant. So could be nothing, but exposed to like foodborne pathogens potentially. His temperature is normal, heart rate is normal, blood pressure is normal. So vitals are normal. He's got jaundice. There's something going on with his liver because it's large and it's not tender. And so he's got no signs of basically like cirrhosis. So the labs are really going to be the key then. So already, I don't know. I guess you'd be thinking at this point, maybe something to do with the liver. I guess you'd probably be thinking hepatitis, but you wouldn't necessarily know. Hepatitis would certainly make sense with the restaurant thing because it's fecal oral transmission, so that would make sense. This is where the money is. So he's got about a little less than 50% of his total bili is direct bilirubin, which both are elevated. So that tells you that's something going on in his liver. He's got much higher elevations of his ALT than his alk phos. You could do the R factor, but again, this already is above 5 times the ALT over the alk phos. So already, even without multiplying it by 3.5, you should already, this is very clearly intrahepatic. So he's got no signs of liver failure, either acute or chronic. And this is telling you, so anti-HAV IgM. So this is positive. So this tells you that he's got an acute hepatitis infection. Because again, hepatitis A, we'll talk about this probably next time or one of the future ones, but hepatitis A only gives you acute infections. So if you get IgG, it tells you that you've had hepatitis in the past or you've been vaccinated. So the fact that he's negative means that he was not exposed previously, and this is an acute infection. Because if he had IgG, this would be a protective antibody. The fact that he's got anti-surface antibody tells you that he was exposed to hepatitis B in the past. The fact that he doesn't have an anti-core antibody tells you that he was vaccinated. So he was vaccinated against hepatitis B. And so, because he also has no surface antigen. Had he been exposed to hepatitis in the past, like a live virus, and he was infected, but he cleared it, then both of these would be positive and the surface antigen would be negative. So he's got an acute hepatitis A. So this is my pathophysiologic chronology. I basically just walked you through the first part of this. Again, the nausea vomiting makes sense because you've got inflammation in the liver. So you got sensitization, presumably of the mechanoreceptors. And so Zach, very graciously shared this gem. So he said, the choice of antiemetic therapy depends on the source of the emetogenic stimulus. Conditions that cause GI irritation, so infections, chemotherapy, distension, result in increased mucosal serotonin release and activation of 5-HT3 receptors on vagal and spinal afferent nerves. These then relay their impulses to the medullary vomiting center, inducing emesis. So that's great. That's actually really useful. So it would make sense that the common mechanism here would actually be 5-HT3. So you're sensitizing the mechanoreceptors. And so now the mechanoreceptors are more likely to cause release for less distension, you'll have more release of serotonin. So that is why you will have nausea. The acute infection, as we talked about, is why you have IgM. And then because he's had a prior HPV vaccination, he was exposed. The vaccination, the key thing to remember is that the vaccine is surface antigen, but no core antigen. So because of that, you'll make an anti-surface antibody, but because you're not exposed to the anti-core, you're not exposed to the core antigen, you will not make an anti-core antibody. So this is our summary of key concepts. I won't belabor it. We went over it, but we will include that in the notes. So questions, concerns, thoughts?
This is a random question, but is nausea is it lessened at all in diabetic patients who have like diabetic gastroparesis or anything like that, or is it altered?
I don't think so. That would be interesting. If you told me that there was a case study of someone with diabetes who had knocked out the afferents from their GI tract, and you could blow tons of air into their GI tract and they'd never get nauseous and distend it like crazy. Yeah, I have no reason to disbelieve that, but I don't know that's like a thing.
Thanks. I'm just curious.
Yeah, good question. Other questions? Asaba says that was super helpful. Thank you. Oh, great. What was helpful specifically?
Just the way that we described everything, I really appreciate having a systematic approach to think through things, because I don't know, tackling things without a clear strategy in mind I don't think that's anyone's first choice approach. But yeah, I just really can't emphasize how much I appreciate giving us a structured approach to these kinds of questions for tests. And
awesome. Thank you. Yeah, I feel the exact same way. Yeah, I felt like I learned a lot of this stuff in very haphazard ways, and I had to piece together with gum and twine a general approach. But yeah, it's interesting. It's much more pleasant. It's just much more fun to practice medicine or to do questions or things when you have a systematic sort of way of thinking about it. Cool. Awesome. Thank you guys so much. Again, we are continuing on with GI. I think there may be a point in which we may branch off a little bit and do a little bit of question interpretation, or I've also noticed there's two sort of steps with Anki. So one of the steps in just learning material in general, the first step that is already a difficult hurdle to clear is, if you get a fact, can you make sense of it and make a good card? So if you get this random fact, I don't know, inflammatory bowel conditions, oftentimes you get tenesmus, right? Can you make sense of that? Can you do something where you can make sense of that? That in and of itself is pretty hard. Most people don't do that. They'll just memorize that. And so you're left without a systematic benefit to knowing that fact. I've noticed that a lot of people struggle with that. I've also noticed, though, that a lot of people really struggle with the idea of mastering a broad topic. So I'm probably going to have something in the course, either in the course or lessons or both, where we talk about where we actually practice this, because I think it's really important. I will say, for people whose scores do not improve, I would say the number one reason is they're just not really learning things very well, or they're not really retaining it very well. That's almost always, especially if your scores are stuck at lower amounts, less than 220, 210 for either step, but especially for step one, it's pretty common to see that being a major problem. So thank you guys very much. I will see you guys next week. We have a lot to cover today, so I want to make sure that we can get through it in a reasonable amount of time. I'm going to read this slowly. A 36-year-old Caucasian woman comes to the hospital for right upper quadrant pain, nausea, and vomiting for the past 8 hours. So just as a reminder, as I'm reading this, I'm actually touching my right upper quadrant so that, again, this is a reminder for me. So she reports similar episodes of pain previously, usually after fatty foods. However, notes that those episodes resolved after 1 to 2 hours. She also notes right shoulder discomfort over the past 8 hours. Family history is significant for gallbladder disease. Temperature is 38.2 Celsius, blood pressure is 138/85, pulse is 95 a minute, and respiratory rate is 18. BMI is 42 kilograms per meter squared. Abdomen is tended to palpation in the right upper quadrant. Labs are shown. Abdominal ultrasound is attempted, but the gallbladder is unable to be visualized. Hepatobiliary scintigraphy shows no visualization of the gallbladder at 60 minutes, with uptake in the intestine. Labs are total bilirubin is 0.5, alk phos is 65, AST 25, ALT is 25, amylase is 75. Hemoglobin is 14.2, platelets are 300,000, leukocyte count is 12.7, or 12,700. Neutrophil is 85%, bands are 1%, lymphs are 13, and eosinophils are 1%. PT is 13 with an INR of 1, serum albumin is 4. What is the pathophysiologic chronology? Be sure to explain the LFTs, including the bilirubin, AST, ALT, and alk phos, quality, frequency, and duration of the pain, and the reason for having nausea/vomiting. Okay, great. So I am going to copy this into the Google Doc, and then I will have you write out your pathophysiologic chronologies. Okay, so I'm going to go through the pathophysiologic chronology. So the big picture is pretty simple, actually. Just has the 5Fs, and then develops gallstones. One of the gallstones gets lodged in the cystic duct and gets acute cholecystitis. We'll walk through more and exactly why that happens, but the basic idea is that you get basically just pressure ischemia, or at least that's the best pathogenesis that I could find for why that would make sense. So pressure ischemia, so you'll have problems with the cell-cell adhesion, and so bacteria then can infiltrate the wall from the bile. So this is a summary of the key concepts that we will be discussing today. We'll be talking about the difference between biliary colic and acute cholecystitis. So biliary colic is basically where you have a gallstone that lodges temporarily in the cystic duct, so it's temporarily lodged in the cystic duct, but it gets dislodged. And so it doesn't cause cholecystitis, which is where it gets stuck in the cystic duct neck. Because it can't be dislodged, then you have basically just pressure, right? Because it's pushing on the wall, literally. And so as it's pushing on the wall, you're going to evacuate blood from the capillaries. You can get edema because you're compressing the veins. And so you can get basically breakdown of the cystic duct wall. And so bacteria can then enter in. It causes inflammation, and that's why you'll get this constant pain that doesn't get better after a couple hours. We'll also be talking about gallbladder imaging. So we've mentioned before that in general, the ultrasound is going to be your first choice, but then we'll also talk about what coloscintigraphy is. So coloscintigraphy is basically a form of nuclear medicine. Again, we'll talk about all this more in depth, but this is just the roadmap of where we're going to go. It's where you inject a radioactive substance basically into their vein. It will travel to their liver and specifically go into the bile. And so the idea is that if you have, right, in cholecystitis, you've got a gallstone that's lodged right here. And so normally the radioactive material should go through all throughout the biliary tract, including the gallbladder. However, if I've got a gallstone right here, then that radioactive material will not, it won't be able to make it past the obstruction. And so you will not see the gallbladder light up like you do normally. So the reason why in the vignette, the gallbladder was not visualized is because there was a gallstone sitting right in there, right in the cystic duct. And so the radioactive material couldn't make it into the gallbladder. So usually a secondary test in cases where you can't see, where it's sort of ambiguous, but you still suspect cholecystitis. And so we'll also end on talking about the Tokyo criteria. So there's a criteria, because again, I never knew this. I didn't learn this until I was an intern. What exactly are the criteria for cholecystitis? This was actually not even something that I learned from, even though I was like a surgery intern for 4 months. It was not something that they taught us. This was something that I had to learn through in this case, I think it was the Hopkins Antibiotics Guide. But we'll talk about the ways of thinking through more systematically how to diagnose cholecystitis. Great. All right. So we are going to start with Joni. So cholecystitis. So again, wordsmith. We want to wordsmith this. So using the etymology, I want you to explain what it is.
Using the word, it's basically an inflammation of the gallbladder.
Yeah, perfect. Yeah. So cholecyst is gallbladder, right? Cyst is bladder. Cola is, I assume, bile. Itis is inflammation, right? So cholecystitis is gallbladder inflammation. Great. And so Nita, So cholecystitis versus biliary colic. So I want you to use the etymologies to explain how they're different.
Cholecystitis is gallbladder inflammation, and biliary colic is referring to pain associated with gallbladder problem with
Yeah.
bile.
Yeah, exactly. Colic, again, technically means like waves of pain that start and stop abruptly. Technically, biliary colic isn't true colic. But the point is that there's no itis. The point that I was trying to make with this is that there's no like itis in it. And so I think, yeah. So we talked last time about biliary colic is technically not true colic since it is a constant pain for a shorter duration, right? However, note that there is no itis in the name. So there's no inflammation. So that's the major difference that I wanted to point out. So cholecystitis means that there's gallbladder inflammation versus biliary colic, there's not gallbladder inflammation. All right, so Siriu, so you may or may not have done the cardiovascular vignettes, but if you haven't, the one that this comes from is number 15. Okay, so if you recall, blood flows in large part because of a pressure gradient. So the aorta has the highest pressure, then the arteries are going to be next, then the arterioles and the capillaries, etc. Okay. And so what's the typical pressure in the capillaries? Do you know?
Well,
Yeah.
I mean, it's higher than the veins, but it's lower than everything else.
Yeah, usually it's about 20 to 30 is a reasonable way to think about it. But 20 is a good number to remember. Okay. So what's the basis of the capillary refill test? When you say like there's good cap refill or there's not good cap refill. Isaac, what do you think?
Okay, this is a way to tell if there is adequate blood flow to tissue. So you would press finger, for example, and it turns white. And then I guess the time it takes for the color to return to the finger indicates if it's well perfused or not.
Yeah, essentially. Yeah, good. So you push on it, right? So you're basically squeezing out the blood from the blood vessels. So that's why it turns white. That's why it blanches. And so then you release the pressure and the blood's going to flow back in. And so how fast the blood flows back in is an indicator, a relative indicator of tissue perfusion. Good. Okay. So pressure ischemia. So what's the basis for this phenomenon? Why? So putting it together, right? Capillary pressure is about 20 to 30. If you press on some tissue, right, the blood evacuates from within the blood vessel. So how does pressure ischemia happen?
So there is pressure that overtakes or is greater than whatever vasculature that you're looking at. I think it was 20 to 30 millimeters per mercury,
Millimeters of
but of mercury. But so
yeah.
whatever
Remember,
pressure that overtakes that.
One of the ways
will
that
be-
they used to measure pressure in the old days was like they'd have a standing column, a small standing column of mercury. And that
Okay.
was how they measured pressure. So yeah, millimeters of mercury.
So whatever pressure overtakes whatever vasculature, or whatever, if the vasculature closes, then there won't be adequate perfusion to the tissue. So then you'll get ischemia distal to the collapse or the pressure.
Yeah, essentially. Yeah, so if you've got external pressure, so common things would be immobility, right? So in anesthesia, when we talked about like how, if not like short surgeries, but like really long surgeries, 12, 14, 16, 18-hour surgeries, like you have to be really, really careful that, you like massage their head or make sure that their head's like supported on like a gel pillow or and that the pressure is well distributed so that they don't wake up with a bald spot because you can give them pressure ischemia to their scalp or an endotracheal tube greater than usually about 2, definitely 3 weeks can give you, if you have an endotracheal tube sitting in the trachea, that cuff, that balloon can cause ischemia to the trachea. And so you can get tracheal stenosis, so you can get tracheomalacia. Gallstone impaction in this case, so if you've got a gallstone that's impacting, it's literally pushing against the wall. And so you're going to decrease the blood flow to the tissue. And so it's not that hard to believe that you could have an increase or a decrease in blood flow causing ischemia. And it can ultimately lead to necrosis if it's prolonged. And because the other thing in the case of cholecystitis is that you've got this gallbladder that's actively contracting. So it itself is also generating pressure. So the pressure in the gallbladder also is going to be higher. And so we talked about, there's no one correct number for what you would need. Unfortunately, it would be nice if there was like, oh yeah, 20 is the magic number. It's not quite that easy, although 20 ends up being a pretty good number to know. Because yeah, intracranial pressure above 20 is definitely concerning. Compartment pressure, if you're worried about compartment syndrome, 20 is a good number to know. But there's no one perfect number. And that's because certain tissues can withstand ischemia for longer. Certain tissues can withstand ischemia for less time. Your brain can only withstand 5 minutes of ischemia, whereas like your muscles can withstand hours of ischemia. So it's going to depend. Okay, so we're going to talk next about cholecystitis versus biliary colic. So acute cholecystitis, what's the pathophysiology? Lady, what do you think?
Okay, acute cholecystitis then will be the result of will be the inflammation. So probably if we say it's gallstone like blocking the cystic duct and then it's causing pressure there and ischemia. Oh, I remember before that blockage, I think it's always gonna be like inflammation, like accumulation of the bacteria.
Yeah, so basically you get, it's gonna block the cystic duct, and then you're gonna get basically a buildup of pressure here because the gallbladder is gonna keep contracting. So it's gonna get really distended and really high pressure. So within the gallbladder, and then also presumably also where the stone is lodged, you're gonna have capillary and venous compression. So you're going to have pressure ischemia. And so if you have pressure ischemia, then it'll be easier for bacteria to leak into the wall, and you can have also necrosis, ultimately having necrosis if it goes on for long enough. Cool. Does that make sense? All right, Lyra. So the initial stages, do they show increased or decreased wall edema, and why would that make sense?
Increase.
Increased, why?
I guess there's like increased, I think, edema is from like, I'm trying to think of the oncotic and osmotic forces.
Yeah, so edema comes from basically fluid that leaks out of your capillaries. So think about it this way. What is the higher pressure, arteries or veins?
Arteries.
Great. So what would be easier to compress? So if I increase the pressure uniformly, what would I compress first? The veins or the arteries?
If you increase the pressure, vein.
Yeah. So I'm going to compress my veins first. Okay. So if I compress my veins...
Oh, the hydrostatic pressure is higher. Oh my goodness. So then it's before the obstruction.
So in the capillaries?
Yes.
So if the capillaries have higher hydrostatic pressure, what will happen to the amount of fluid that leaks across the capillary walls and thus giving you edema?
It'll increase.
Yeah, it'll increase. So what I'm trying to show, again, this is, I'll have a more formal lesson on this at some point, but we've talked informally before about the idea of details versus themes, right? So you can memorize the stages of cholecystitis, or you can just think about it, like you can just recognize the concept that's happening. Yeah, you can memorize, okay, well, the first stage is going to be 2 to 4, it's going to be edematous, right? And then stage 3 to 5, you're going to have necrotizing cholecystitis. And again, that should make sense because over time, necrosis, remember, is different from apoptosis. Necrosis happens when the cell is ischemic for too long and it just dies. As opposed to apoptosis, where the cell is making it's not really a conscious decision, but the cell is deciding to die, right? It's suicide versus like murder, right? So necrosis is murder, right? So the cells are basically being murdered because they're ischemic for too long and it's not apoptosis because the cells aren't deciding that they need to die. So if you want to know more about the stages, you can read this whole article. But again, I'm pointing this out because the concept is actually pretty easy to understand, right? You're going to see edema first, and then over time, right, when you have ischemia for too long, you are going to get necrosis. This is presumably the reason why when you have cholecystitis, you need to take the gallbladder out within 72 hours. So great. Cool.
That makes so much more sense to me. Thank you.
Okay, so Nicole, acute cholecystitis versus biliary colic. So use the pathophysiology to explain how long the pain would last.
Okay, so for biliary colic, I think that the pain is shorter or I think that if you pass the stone, then I guess the pain would pass, and it only occurs during the contraction of the cystic duct, I think, or
it actually doesn't.
Yeah.
That's what I thought. That's what I used to think.
okay.
And that would make sense. That would make total sense, especially because colic just totally throws like the word colic. It's just saying, because normally we think of colic as like pain only during contractions. So I think I gave you a fake out before because
you said it was because of like the distension, right? Like
yeah,
that
well,
one?
biliary colic itself,
Okay.
biliary colic itself is a misnomer because it's not technically a true colic pain.
Okay, wait.
It is episodic though, so you were correct in that.
After
Right? So it usually lasts for about an hour or two. Whereas cholecystitis, how long is that pain going to last?
I guess that would be a chronic because it's
Yeah, and it'll be consistent. Yeah.
Yeah.
Exactly. So cholecystitis does not make it better
Can I
than
ask a
it
question?
All it does. It's because which makes sense again, because it's A, ischemic, B, inflamed, and C, potentially necrotic, depending on how long it goes, whether the cells are like.
Can I ask a quick question about this, about the duration? Or actually, it was about the previous one with the necrosis. So I know this is a little bit unrelated, but like I know you said in the timeline, the 5 days, it takes 5 days for the necrosis to occur, and you need to take it out within like 72 hours. How long would it take for someone to form like that fibrotic one? What is it called? The porcelain gallbladder? Is that something that would?
Porcelain gallbladder is
within
different.
these 5
Porcelain gallbladder, we will probably not talk about that formally, but yeah, porcelain gallbladder is, I think, months basically. Like my understanding of porcelain gallbladder, and I could be completely wrong about this, but my understanding of porcelain gallbladder is because you have a chronic inflammatory process. If you recall, again, the theme, the concept is dystrophic calcification. right? So anytime you have chronic damage, you can get dystrophic calcification, right? So calcification of basically dead or damaged, dying or damaged tissues. If you get inflammation for long enough, you can get calcification just because of dystrophic calcification. So that's my understanding of why the porcelain gallbladder happens. But it is assuredly because of chronic inflammation. It is assuredly in situations of chronic inflammation. My assumption is that's why. It might be hard to prove. I don't know how you'd prove that. I don't know how you design like a randomized experiment to do that, but that would, yeah. Okay, so next up we have Paul. So acute cholecystitis versus biliary colic. So I want you to use the anatomy of the biliary system to explain what the LFTs would be.
I think the LFTs would pretty much be normal, and then biliary colic, because you might have obstruction on the biliary tree. You have elevation in your...
Remember,
Enough
alk phos
about it.
happens, so it's not because you get obstruction in the biliary tree specifically. Where is alk phos actually synthesized?
I thought it was in the epithelial cells of the duct cells.
No, interesting. That's what I thought too. I thought that too. And then because I was trying to figure out, like, why doesn't that make sense? Apparently, it is actually in the hepatocytes that face the ducts, but it's actually in the hepatocytes. So what that means is that you can't just block anywhere. It actually has to be an increase in pressure
Intrahepatic.
in the ducts that are intrahepatic. Cool? Does that make sense? Yeah. So basically, they're both normal, in other words. Because when I started, I was like, oh my gosh, if it has anything to do, I had a very simplistic view. I was like, if there's any amount, right, if there's some problem somewhere in your biliary system, then yeah, there must be an increase in bilirubin and there must be an increase in alk phos. That's sort of what I assumed. And sometimes you can. I mean, remember, there is still like bile in your gallbladder. So presumably you could get some, right? But it's not significant. It doesn't show up in a very substantial way. Cool?
Yeah.
Yeah. So duct facing hepatocytes. Yeah, I found that
Sorry,
really
can I ask-
surprising.
For the ALP, so is it only found in the or okay, like you know how it's also elevated in like bone diseases or something?
Yes.
Why? I mean, is it only made in hepatocytes
No,
or
it's
is
made
it
in
found-
many places, including, yeah, we've talked about it. Go to, I think we
Okay,
talked about it in
okay.
the first GI lecture. But yeah,
Okay,
the
I'll look
punchline is yes, it's not just in the liver. But when we're talking about in the liver context, it is made in bile duct facing hepatocytes. Okay, Rongsini. All right, this is harkening back to GI vignette 7. So if you guys want to recap of this, you can go back to GI vignette 7. But how does ultrasound work, generally speaking?
So the ultrasound, I think you use like a sound wave, and then if you found anything that is a solid mass or something, it will send the signal back to the detector or something. I'm not sure, to the probe.
Yeah, it's basically sonar, right? You're
Mhm.
basically like, if it takes longer, so it's a sound wave. We know roughly how fast it's going to move, how fast the sound wave is going to propagate. The longer that it takes to go there and back, right? So you've got something that both emits sound and then can absorb sound in the probe. And so if it takes longer for it to go there and back, it must be farther away.
Okay.
Versus if it's close, right, it's sort of like, if you drop a rock into like a deep pit and it takes forever for you to hear the sound, it takes a really long time for you to sound, that pit is really deep because it took so long for A, the rock to hit the bottom, and B, for that sound to come back to you. That's the general idea. Great. And so,
Okay, thank you.
yeah, of course. So Zane, what is the enemy of ultrasound and why?
The enemy of ultrasound? I don't know. I have no idea.
So so sometimes you'll see this, people will say this, and the enemy of ultrasound is air, right? So air, the reason why is because basically you're causing, I think there's a number of reasons, but I think the simplest reason is that you have the sound just gets scattered, right? And so you don't get much, if any, sound that goes back. So first of all, like the sound can't make it to the object that you're trying to measure, like a tumor, let's say. But second of all, like the sound is going to be scattered. So very little of the sound is going to make it back to the probe, period. So air is bad. This is why you have gel on, virtually always, you will have some sort of gel, at least when you do ultrasound externally.
So how would you interpret that? I'm sorry.
How would you interpret what?
Like in acute cholecystitis, for instance, you normally do an ultrasound
First.
After the HEDA scan, maybe, how would you interpret that?
Oh.
So does the sound come back faster and slower?
Oh, no. We don't have enough time to be able to go into like that find of how you would measure. This is just a very theoretical way of thinking about how ultrasound works. But yeah, it's what you're looking for. Like you can see, the punchline is you can see things like edema, right? So it's not that like sound I don't know, maybe it does change the character of the son that comes back. But yeah, you can see things like edema on ultrasound. It has a characteristic look. All right. So Jared. So I want you to use this picture and I want you to tell me, what would you not want to do? How would you not want to image the pancreas? And what would you use instead? So the pancreas is right here.
You probably wouldn't use an ultrasound because there's not like a clear view. There's too many things obstructing it.
But what things are obstructing it? Because again, things obstructing it aren't a big problem. It's the kind of things that are obstructing it that are going to be the problem.
Predominantly it'd be the stomach, and then
what's the enemy?
It would be air is the enemy. So like parts of the stomach that are empty would have lots of air in it.
Yeah. Empty doesn't necessarily imply that there has to be air, and full doesn't mean that there can't be air. But the point is that you have, I mean, you burp and you fart, right? And so your GI tract is full of air. So in a general sense, you do not want to ultrasound the pancreas because it's surrounded by structures that are full of air.
And instead of that, you would use a CT scan.
Yeah, good. Exactly. Interestingly, I think that my daughter, we had an ultrasound recently, and one of the things they said is don't pee before the ultrasound. It was an abdominal ultrasound, and she's okay. But I think that the reason why, I didn't ask, but I think that the reason why is because you want the bladder to be full because it will transmit the ultrasound waves pretty well, and so it actually helps with visualization. That'd be my guess, and why they said not to pee. But I could be wrong. Yeah. So CT is what you want to do. Right, because again, CT works via, it's basically like, it is just x-rays. And so that works just via density. So it doesn't matter if there's zero or not. Okay, so Mary, so liver. So use the abdominal anatomy to explain how effective ultrasound would be as a diagnostic tool. Would it be good or not good?
I think it'll be good.
Good, why?
Because it's a solid organ and also you have a good vision.
There's not a bunch of like air containing structures in front of it. Yeah, you can just stick your probe right here and you can see in the liver. Good. Sophia, how about the gallbladder?
It's also good for that. I guess you do have air-filled structures nearby, but I think you're usually interested in the part that joins the liver, so it should generally be fine.
Yeah, well, but again, think about how you're looking at gallbladder. You're looking at the gallbladder from here, not from this side. You don't have to look through the stomach to look at the gallbladder. You can look through the liver. And again, you can see it pretty well because again, the liver is not full of air. It shouldn't be.
Right.
Yeah, good. All right, Devin, how about the spleen? How effective would ultrasound be for the spleen?
It would be a good source for looking at the spleen.
Yeah, exactly, same reason. Okay, so we talked about, so cholecystitis. So the strongest risk factors for cholecystitis, Devin, let me ask you, because I think you referred to these before. So what are the strongest risk factors for cholecystitis? For gallstones, cholesterol gallstones?
The Fs.
Mm-hmm. So what are the Fs?
Fat, female, fertile, family history, and fair skin.
Yeah, good. So is it 40?
I think last time we talked about it, you said the literature doesn't necessarily support it being like a definitive thing.
Yeah, exactly. Interestingly enough, I mean, I think it probably did at one point, but my guess is that at least the article that I read, this article, speculated that the age probably matters less now because so many more people are obese sooner. Like that that age is being basically like crowded out by other things like family history or just larger amounts of like childhood or earlier onset obesity. But yeah. Okay, good. So cholecystitis. Ayat, are you there? Use the risk factors for gallstones to explain why ultrasound may be difficult for visualizing the gallbladder in some patients.
Okay, so the risk factors we said are the 5 Fs. Yeah, so if someone is fat, that would, because of so much fat, that would prevent visualization.
Yeah, exactly. So remember, if you've got a lot of adipose tissue, so let's say this is the ultrasound probe, right?
Yeah.
If there's a bunch of adipose tissue, it's just that much farther away. It's just harder to see. As a general rule, the farther away something is from your probe, the harder it will be to see.
Okay.
Because sound is going to attenuate, and there's a variety of reasons.
So it's just because of the fat. Okay.
Yeah. So the downside is that ultrasound is great in theory, but sometimes, right, the people that are at risk of cholecystitis or getting gallstones in general are also the people that may be hard to get a good view of the gallbladder.
So why is it still a good test if that?
I think it still works pretty well. I can't remember. I don't know that I found like a specific number of like how many people like can you not see the gallbladder in, but it still works quite well. And remember, use ultrasound for things like you can see structures. And I mean, like your aorta, right? You do ultrasound to look at like the abdominal aorta. That's a pretty deep structure. Ultrasound is pretty powerful. You can still see pretty deep structures. But yeah, if you've got a BMI of 45 or something, It may not work that well. All right, so Joni, so what is the basis for nuclear medicine scans? We talked about ultrasound, right? Ultrasound is where sound comes out and then comes back in, and you basically are measuring how long it takes for it to go, and you do a bunch of fancy calculations to get a good image, but fundamentally that's basically what you're doing. So what's the basis for nuclear medicine scans?
I'm just wondering, when we're talking about nuclear medicine, are we referring to CTs or?
No, great question. We're talking about like PET scans. We're talking about thyroid scintigraphy, right? So the radioactive thyroid, like radioactive iodine test.
Oh, okay.
For the
I
thyroid, we're
understand.
talking about HIDA scans, right? Like this, like the cholescintigraphy. Those are nuclear.
Right. Okay, so does that mean we're gonna have to use some form of material to
Material?
like what's that?
Material that gives off what?
Like radioactivity, right?
Exactly. Right?
General.
So why do you think they call it nuclear medicine?
Good question.
What do you think of nuclear?
Because
If I say like nuclear, like a nuclear power plant, like what is it? What is it doing?
well, I think of chemicals generally. I mean, I don't know.
Chemicals, but yeah, things that are going to give off radiation.
Yeah, like elements of the periodic table or
That's
something like
essentially what
that.
nuclear medicine is. So
Yeah.
how does it work though? Do you remember? We talked about this in cardio vignette 14.
I don't know. I right off the top of my head, I could think of like a barium scan or
Barium's a little different, actually. Yeah. So
Okay, so
generally
for-
speaking,
yeah.
the way that nuclear medicine works is that you have some sort of substance. You're pretty close, but the idea is that it has an unstable nucleus. So I
Okay.
injected, so just like a nuclear bomb has an unstable nucleus, and so
Got it.
in that case, it's like really unstable. But yeah, so you've got an unstable nucleus, and so it decays, so it breaks apart, and then as it breaks apart, then it emits electromagnetic radiation.
Oh, okay.
I detect that electromagnetic radiation. Okay.
So that makes sense.
Yeah, so basically, I inject something into your body, and then when it decays, it releases like a photon that is detected outside the body. So keep that in mind. I've got a picture to help illustrate this. I've got a number of pictures to help illustrate this, but keep that in mind. So Devin's asking, so glucose is radioactive? No, so glucose itself is not radioactive, thankfully, for those of us who enjoy.
Yes, I was confused.
But yeah, so what they do, so like a PET scan, what they do is they radio label glucose. So I think they use, I want to say they use fluoride. I honestly don't remember. Or maybe they change one of the carbons. Somehow one of the nuclei is replaced with something that is radioactive. So it's a special form of glucose. So
It's 5-fluorodeoxyglucose.
5-fluorodeoxy. But the radioactive element is fluoride?
Yeah, I believe so.
Yeah. So they tag it with something radioactive. There's, I mean, lots of ways you could do it, but the fundamental thing is that you have put some sort of radioactive atom there. And so that atom is going to decay, right? So glucose is going to go to places where glucose go, right? So in the case of a PET scan, it's because tumors usually do not use their mitochondria very well. So they rely heavily on glucose because they can't do the electron transport chain, which is in the mitochondria. So they rely heavily on having glycolysis. And so if you give glucose to someone, a large portion of that glucose is going to go to the tumor. Again, not all tumors are like this, but most. And it's known usually which tumors are going to be, they call it like glucose avid. And yeah, so the glucose will go to the tumor, and then the fluoride or whatever the element, the radioactive element is, will decay, and then it emits light, and then you can back calculate. You've got like this cone basically that surrounds the patient, and so you can back calculate because there's basically 2 photons that come out, and so you can calculate out like where the photons are coming from. Cool, makes sense. So Sophia says it's F18. Yeah, so it must be the fluoride that is radioactively active. 2-deoxy. Interesting. Okay, so Nita. So can you explain to me how is nuclear medicine different from X-rays or CT scans? So this was our point of confusion before.
So with nuclear medicine, you mentioned that you're giving something that gives off radiation that you're detecting, whereas with X-rays and CT scans, you're shooting radiation at the patient.
Yeah, perfect. That's pretty much it. And so what are you looking for in terms of X-rays and CT scans? Like what causes some things to be brighter or not as bright?
Density. So CT, I think, does soft structures too. It's got more contrast.
That's
like
it. Yeah. I
ability
guess-
to contrast the image, and
Right.
X-rays. Yeah.
Yeah, exactly. Yeah, good. So nuclear medicine, you're basically, the radioactive material enters the body, and then it emits radioactive electromagnetic radiation from within the tissues. Okay, so it goes to the tissues of interest, right? So if you've got in like a PET scan, it's going to go to the tumor. It's going to go to a lot of places, but one of the places it's going to go is the tumor. And so from the tumor, it's going to like emit a lot of radiation from within the tumor. Whereas a CT scan, if I was going to do a CT scan of the same tumor, I'm going to basically shoot X-rays, electromagnetic radiation through the body. And then if the tumor is more or less dense, it's going to have a density that's different from the surrounding tissue. And so I'll be able to see it. So fundamentally, they're different. So an X-ray or CT scan is basically like this. So I've got an X-ray source, and on the other side, I've got some sort of detector. And so an X-ray basically shoots through, and as Nita pointed out, it works on the basis of density, right? So more dense elements, right? So things that are lower down, the punchline is that lower down on the periodic table elements are going to have a greater density. So they're going to be basically, it's going to be harder to get X-rays through them. And so if something's really dense, then you won't see anything on the other side. So if you don't see something on the other side, then the way that they develop X-rays is that it ends up being white. So bone has a lot of dense elements like calcium and things like that, calcium and phosphate. And so X-rays do not pass through bone particularly well. And so they end up as white because they're not detected. Whereas lungs are black because X-rays pass through it really well because there's very few elements, period. And the elements that are there are not particularly dense. And so they end up being really black because almost all the X-rays that go through are going to pass and be detected by the detector. So again, external X-ray, external radiation source passing through, and then you detect it on the other side. And so if you detect it, it ends up being darker. Whereas in nuclear medicine, fundamentally, it's different. So in nuclear medicine, I'm injecting some sort of radioactive material into your veins. It's going to go, again, it depends, right? If it's a thyroid, it's going to go to if it's like radioactive iodine, it goes to your thyroid. If it's glucose, it's going to go to all of your tissue, but particularly to the parts of your body that, like a tumor that's going to need a lot of glucose. Or in the case of a HIDA scan, it's going to go to your liver. And so it's going to go to your liver. And it's going to go specifically, it's excreted in your biliary system. And so it gets excreted, and it's going to go all over your biliary system, including to your gallbladder. And so then it's going to decay. So some of it's going to decay here, some of it will 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 make it to your intestines and decay here. But the point is that you're going to see basically an outline of your biliary system / liver. Right? So you can see, right, early on, it's in the liver, and then it starts to be a little bit in the gallbladder. And then over time, right, this is the gallbladder, over time, then it goes more and more, right, through the rest of the biliary system. And then eventually you can see it go to what I assume is the small intestine. Cool. Makes sense. Let's start with Lyra, and then we'll go to Sophia next.
How long does the HIDA scan take to do, and like how fast does it start to decay?
I think it's about an hour. I assume it decays like immediately, right? It's decaying like constantly, but it takes about, I think, an hour for it to be able to visualize the gallbladder. I think Sophia had a question.
Yeah, I was just wondering why we use iodine. Is there like a tropism for gallbladder, hepatic?
No. Sorry, let's be very clear. It is not iodine. Sorry, I should maybe rename the slide.
Oh, that is the thyroid one.
Yeah, this is just for thyroid.
Right. And
yeah, so colography. Sorry. It is not iodine.
And it's a different
I forget
one.
what it is. Well,
okay.
it's actually HIDA. HIDA is the agent that is, I forget what it stands for.
I can look it up.
There is a specific, I forget what it's called, something acid. But yeah, it is a compound that goes to your liver and is excreted in your bile, and they radioactive.
Thank you.
Iodine, again, the major organ in your body that uses iodine is your thyroid. So that's why I think it's like a perfect thing for thyroid scintigraphy.
Exactly.
I have a question. If we have ultrasound, what are the indications for a HIDA scan if
you can't see
ultrasound like
gallbladder.
okay.
There's others too. Like I know that there are others. So Isaac says HIDA is hepatobiliary immunodiacetic acid. Yeah, it's not always HIDA. They don't always use HIDA, but the name is kind of stuck because that was, I presume, the first first major thing that we use. Yeah, HIDA scans are not that common. They're not that common. They're not that common. But yeah, it's basically if you can't visualize the gallbladder. The major times that you will see it for the USMLEs, I'm sure there are other indications, but the major time that you will see it for the USMLEs are if you think that they have cholecystitis and the ultrasound is giving you like not great results because they're too fat because you can't see the gallbladder or because something. It's like a confirmatory test. But again, it comes up not infrequently. And again, it's fundamentally, it's not that hard. If you understand the concepts of nuclear medicine, it's actually not that hard. It actually makes a lot of sense. It's just when I was at your stage, I was just kind of like memorizing this stuff. And it didn't really make sense to me. And I didn't really have a good understanding of what exactly is nuclear medicine? How exactly is that different from an X-ray? But yeah, it's actually not that complicated. we'll finish with this. So again, X-rays, external radiation passes through something. Nuclear medicine, the nucleus is basically within the tissue of interest, and so the radiation is then detected. Usually, it's detectors like on all sides, basically, because you can, through fancy math and stuff, you can triangulate where it came from. But that's essentially what you're doing. So yeah, so that is a HIDA scan. So how does a HIDA scan work? So walk us through again. You can use this handy dandy. You can use this handy GIF, animated GIF that I made to help you.
It's like scintigraphy, right? It uses radioactive material, and then the material decays, and then it like spreads.
Yeah, but if I just injected radioactive material in you, it's probably not great, right? Like, so what's special about the radioactive material that I give you for a HIDA scan or a cholescintigraphy scan?
It brightens things. And in this case, the gallbladder.
Yeah, but why?
Not sure.
Because where does it go, right? Because remember, if I wanted to look at your thyroid, would I do a HIDA scan? Would I give you the same substance as I would give you for a HIDA scan?
No.
Yeah, exactly. So in a HIDA scan, because iodine goes to the thyroid, HIDA goes to where?
Goes to the gallbladder.
Yeah, well, it goes to the biliary system. Yeah. Oh, yeah. So here we go. Hepatobiliary aminodiacetic acid. So it's HIDA. Technically, it's oftentimes we're not actually doing a HIDA scan because oftentimes we're not actually using hepatobiliary aminodiacetic acid anymore, but the name is kind of stuck. But technically what we're doing is cholescintigraphy. And so a radioactive tracer is injected into the veins, which accumulates in the biliary tract. And so you can then basically light up, so to speak, the biliary tract. So cholescintigraphy. So I want you to use what it is to explain what it is often used for. Actually, I already talked about this, but Isaac, what do you think?
Something that is blocking the cystic duct or the bile ducts.
It's basically used for cholecystitis. I mean, again, there are other things. If you look up indications for HIDA, cholescintigraphy, there's a longer list of things. But I would say the most common one that you'll see, at least on the USMLEs, is to confirm cholecystitis if ultrasound is negative or inconclusive. Good. All right. So cholescintigraphy. So use what it is to explain whether the gallbladder would be visualized in acute cholecystitis. Why or why not?
I think if it's for acute cholecystitis, if the inflammation isn't blocking off the cystic duct, then it should still be able to go into the gallbladder and completely light up the liver all the way.
That's true. What's the most common cause of acute cholecystitis?
Gallbladder, a gallstone obstruction.
Good. Where?
A cystic duct.
Great. Okay. So in that
okay.
You are correct. So if it was there is such a thing as, it's called acalculous cholecystitis, right? So acalculous meaning not calculus, not stone. So, yeah, you would presumably see the gallbladder. However, that's like the very tiny minority of the cases. If it is
but yeah. So if it is due to the fact that there is a gallstone stuck in the cystic duct, then I wouldn't see the gallbladder.
Perfect. Yes, exactly. So most of the time for acute cholecystitis, most of the time, right, 90+% of the time, it is due to obstruction of the cystic duct, right? So if I've got a honking stone here that's causing backup of pressure, causing necrosis, pressure necrosis, and stuff like that in the gallbladder, then that gallstone, not only is it preventing stuff from leaving the gallbladder, but it's also preventing stuff from entering the gallbladder. So it would not be visualized. Good. Again, if you understand this question, this is like the money question for most of this lecture. If you understand this, you understand most of what you need to from this lecture. This is a particularly important question because, again, look at this. We've tied together the pathophysiology of acute cholecystitis, right? Nuclear medicine, how like cholescintigraphy works. Like, if you can answer this question and really understand it well, it means that you understand a lot of related topics. Okay, so the last thing we're going to talk about is the Tokyo guidelines, right? Because you want to, how do you actually diagnose these things? This is something that, again, you may think, oh, I don't need to know this, but it actually is pretty useful. I actually find knowing the diagnostic criteria, certainly in life, is useful, but also on tests, it's surprisingly useful. Why? Because the test writers have to follow specific rules, right? And so one of the rules that you need to know is that they have the cover the responses rule, which means a group of experts sitting around a table should be able to cover the answer choices and all come to the same conclusion of what the right answer would be, which means they have to give you enough information in the vignette to make the correct diagnoses. And the only way for that to be true is if they meet the diagnostic criteria. So I've got one question from Miri. Actually, we'll go to Miri's question next. But so I want you to understand, it is really important that you know the diagnostic criteria. So I'm going to guess that you probably don't know the diagnostic criteria. Lady, do you know the diagnostic criteria by any chance for acute cholecystitis?
I think I don't know, I'm not sure, but I think it will be like the Murphy sign, which is the like
Okay, good. So that is one of them. So local
yes.
inflammation is one of them, right? So localized pain. Good.
Okay.
So of
And
which
then fever, leukocytosis in the
good. Systemic inflammation is
wow.
second. Good. So local inflammation,
Yes.
systemic inflammation. There's one more.
The imaging probably.
Oh, wow. I'm impressed. That's really good. Yeah. So again, sensitivity is 91%, specificity is 97%. Pretty high, actually. Pretty high. So local sensitive inflammation. So Murphy's sign is one of them, right? So Murphy's sign is where you basically put your hand, you curl your hand under their ribs, and then you have them take a deep breath, right? Because when you have to take a deep breath, then their diaphragm is going to descend, their liver and their gallbladder are going to descend. And if the gallbladder is inflamed, that inflamed gallbladder is then going to be you're going to push it, you're going to be pushing on it with your hand. So it hurts, it'll hurt if they take a deep breath and you have your hand basically pushing on their right upper quadrant. But also a right upper quadrant mass or pain or anything, basically any signs of local inflammation. Systemic inflammation, so fever, CRP, leukocytosis, and then imaging. So pericarditis. So I think someone asked before, like, how would you diagnose it? Again, it's not, you don't do it based on like distance, like, oh, the distance has now changed. Like what you look for is things like if you see fluid around the peri is around cholestistic is gallbladder fluid. So fluid around the gallbladder, if you see edema, if you see gallstones, if you see like debris, stuff like that. So suspected diagnosis basically means the first two, right? So basically the inflammatory one. So local inflammation, systemic inflammation. And then the confirmed diagnosis is if you've got all three criteria that are met. So again, that's pretty good. Sensitivity, 91%, specificity, 97%. That's pretty good. All right. I think we had a question though from Mary. Mary said, so if cholecystitis is due to another cause, in other words, if it's not due to a gallstone, you could not diagnose it with HIDA. That's correct. If the question that you're asking, really good question, yeah. If the question that you're asking is there a gallstone blocking the cystic duct? That's basically the question you can answer with HIDA. Or, I mean, again, if you could also answer the question, is there choledochal lithiasis, right? Is there a common bile duct stone? Isaac's asking, would you ever use a CT scan to diagnose acute cholecystitis? Sure, I'm sure you would. Yeah, I think that's also done too. Sure. This is getting, although, beyond my understanding of a lot of these things. But yes, I'm sure. If you ever say, like, would you ever use blah, blah, blah? But I would say, generally speaking, the sequence is ultrasound first, then HIDA scan, then maybe CT. But again, I'm sure that there's going to be regional and personal variation in that. Okay, we are back to our vignette. So I'm going to have you write out your pathophysiologic chronologies or revise your pathophysiologic chronologies, and then we will go over it again. Okay, so I'm going to walk through and I'm going to analyze it myself, going sentence by sentence. Okay, so a 36-year-old G3P3. Okay, so she's had 3 kids, Caucasian's a white woman, comes to the hospital for right upper quadrant pain, nausea, and vomiting for the past 8 hours. So based on the first sentence, so nausea, vomiting, again, non-specific, could be because of obstruction or because of inflammation of anywhere, basically in the GI tract. Right upper quadrant pain for 8 hours makes you think that there's probably some kind of inflammation in the right upper quadrant. Certainly, like, cholecystitis would be high on your list. I guess hepatitis would be the other thing. Could it be something else? Yeah, but that would be the top 2 things on my differential. Probably not biliary colic because, again, it wouldn't last for 8 hours. She reports similar episodes of pain previously, usually after fatty foods. Okay, so that sounds like she's had biliary colic previously. However, notes that those episodes resolved after 1 to 2 hours. So in other words, she's had episodes where stones got stuck in the cystic duct, but then it was resolved. Now it's got stuck. And so it's now causing cholecystitis. So by the second sentence, I would think, okay, I would have a high index of suspicion for cholecystitis, acute cholecystitis. She also notes that for the past 8 hours, she's had right shoulder discomfort, which again makes sense because, again, inflammation of the gallbladder can cause irritation of the diaphragm. We didn't talk about referred pain, but we did, I think, last time or the time before. And so, again, this is just an example of referred pain because you have the poorly innervated internal organs that are going to basically get confused and think, oh, okay, well, it's actually coming from the dermatome, right? So the phrenic nerve innervates the diaphragm, 3, 4, 5, and then 4 and 5 also innervate the skin for the shoulder. So again, still thinking cholecystitis, family history significant for gallbladder disease. So now they're just saying, okay, these are all the risk factors of getting gallstones, cholesterol gallstones. So family history is one of the biggest. Multiparity, right? So fertile or having basically any prior pregnancy. So she's had 3. She's white, so fair. And then we'll see if she's got other ones too. So temperature is high, makes sense. So signs of systemic inflammation. So if we think about the Tokyo criteria, this would meet the systemic inflammation part. The fact that she's had red epicardial pain would be the local inflammation part. So she would meet the criteria based on, she'd be suspected cholecystitis already. Blood pressure, which again, it's interesting. It's interesting to know the diagnostic criteria because again, basically any signs of systemic inflammation plus like right upper quadrant pain, that in and of itself is enough that you should suspect cholecystitis, at least based on the Tokyo criteria. So blood pressure is 130, so it's high, probably because of the pain. Pulse is high-ish, also probably because of the pain. Respiratory rate is high, also probably because of the pain. Interestingly, the blood pressure is not low, so it's not like she's like septic. So that makes sense. This is just pain. BMI is really high, so she is technically morbidly obese. So again, she's like, I got at least what, 1, 2, 3, 4 of the criteria. At least 4 of the 5 criteria for cholesterol gallstones. Abdomen is tender to palpation in the right upper quadrant. Again, basically telling us what we already knew. Again, that's the local inflammation part. Abdominal ultrasound is attempted, but the gallbladder is unable to be visualized, again, because your BMI is 42. Hepatobiliary scintigraphy, so a HIDA scan, shows no visualization of the gallbladder at 60 minutes. Again, which makes sense. That is because you've got a stone obstructing the cystic duct. So that's the third criteria. That's the imaging criteria. So she is a definitive diagnosis for cholecystitis at this point, based on the Tokyo criteria. Basically, the LFTs are normal. Bilirubin is normal, alkalis is normal, AST/LT are normal, amylase is normal. Again, for someone that comes in with abdominal pain, you would potentially could be pancreatitis, but in this case, it wouldn't make sense. So hemoglobin is normal, platelets are normal, leukocyte count is high. Barely, but it is high. So again, that would also meet the systemic inflammation part. PT is normal, serum albumin is normal, again, telling us that there is normal synthetic function, which again makes sense. This is the gallbladder. This shouldn't affect the liver function at all, nor should it give us abnormal LFTs. So great. So you just walked through the pathophysiologic knowledge. All right. That is basically what we just talked about here. So you can look at that again. This will be in the notes. You can look at this more carefully. I also put this in the Google Doc if you're interested. And then we are back to the summary of key concepts. So I won't go back over this, but I will ask for questions because again, we covered a lot of material. And again, this is something that is very poorly understood. I don't think I understood HIDA scans, even as a resident. I don't really think I understood them in a deeper way. So I'm sure that there are things that I didn't explain particularly well. What questions, comments, concerns do you have?
Quick question regarding systemic and local inflammation markers. WBC neutrophils were up. So would that be systemic or local? Can you go over the lab values at the very end that you did?
Yeah. So
regarding
systemic are things that like would be elevated in any form of inflammation. So fever. So they had fever and high white count. So that would be systemic signs of inflammation. The local signs of inflammation were basically Murphy's sign and the right upper quadrant pain / tenderness.
Thank you.
Does that make sense? If I stub my toe, I'll have local signs of inflammation. It'll be red, it'll hurt.
So the lab values are more specific to systemic, and then the clinical findings are more localized.
Yeah, exactly.
Thank you.
Got it. Other questions? That's a good question. How was this? Was this too much? Like I tried to, it's fun to do stuff like this to me, because it's like, you can see all of these different concepts coming together. Like, I mean, cholecystitis is like a really very basic, bland diagnosis, but there's so many things that, there's so many concepts that can overlap in it, like the kinds of pain. We didn't talk about like nociceptive and neuropathic pain, but like that concept, referred pain, nuclear medicine, ultrasound. Like there's so many concepts. Fun, but it can also probably be overwhelming. Sophia says, I think the previous lessons with nuclear medicine set the stage for the HIDA scan to be easy to understand this time. Yeah, that's the other thing. Yeah, my hope is that if you've done the prior lessons, particularly the ones in nuclear medicine, that bringing it back will just reinforce those ideas. Because again, the argument that I would make to you is that there's not that many concepts in medicine. There's not really that many. I mean, there are a number, certainly more than in like physics or something like that, but there's still like a limited number. The key is to recognize those concepts when they come back again and again and again. So you don't have to memorize X-ray here, CT here, like CT here, or like nuclear medicine is actually a really good example. Like you don't have to memorize like, oh yeah, PET scan, like how exactly does a PET scan work? And oh, how exactly does like the radioactive iodine test work? And how exactly does a nuclear medicine scan for like the sestimate for like the heart work and how does like a HIDA scan work, right? Like fundamentally, they are all the exact same. It's the exact same concept. It's just that what you're using to carry the radioactive like isotope is going to be different. And the thing that you're using is going to then change where that radioactive isotope goes. So in a test, maybe it goes to the heart. So you can look at heart perfusion, right? In a radioactive iodine test, it's going to the thyroid. And so you can look at thyroid uptake of iodine. In a HIDA scan, it's going to the biliary system, so you can look at the biliary system. But again, it's just one concept. That is just one concept. So what I like to do is once we've learned the concepts, then just bring it back and just show you again, oh, yeah, this is just that same concept. So I'm glad to hear that you made it easier this time around. Mary's asking, step 1, would they ask about the Tokyo criteria? No, they wouldn't ask you. So again, they wouldn't ask you, even in step 2, they won't ask you the criteria. So you would be justified in saying, or in thinking, do I really need to know the Tokyo criteria? That's totally legitimate. You don't actually have to know this. I find it really useful, however, to know the diagnostic criteria for the USMLE specifically, and also for life. It's actually really useful to know in the real world too, but it's also really useful because they have to, right? Like take psych, for example. You have to meet the criteria for major depression for it to be major depression. They have to give you all the criteria for it, or enough to meet the diagnosis, right? So that's why they will always tell you when the symptoms started. Because again, if they don't give you enough criteria, then it's not a fair question. You can't answer it. I think someone was about to say something.
A real quick question. I don't know if my concept for the bacteria, I don't where that's coming from. I understand that the capillary hydrostatic pressures increase, so there's at least edema because of the veins collapsing and then back up with the capillaries. Does that cause leakage of bacteria as well? How does that exactly work?
So there's bacteria, not always, but there is not infrequently bacteria that is in the bile.
Okay.
So just think about it, right? Like, why don't the bacteria ever cause inflammation in your gallbladder by themselves? Right? It's because you have effective epithelial barrier.
Okay. So the epithelial, it's damaged and then it translocates in there.
Correct.
Okay. Thank you.
Nita, we were able to say something?
Oh, I just wrote it in the chat, just confirming that I liked it because it's a good blend of step 1 and step 2. And I have had questions about scintigraphy before and saying that it wasn't lighting up the gallbladder. And I was like, oh, that's good. So the gallbladder is the problem. I didn't really understand what was going on. So that's really helpful. And I do think I like knowing the Tokyo criteria because, doing some step 2 questions, it gets really confusing unless you know the exact criteria to make a diagnosis. So that's really helpful.
Yeah, I have come like a complete 180 on this. I remember there was a number of lectures that they taught us, like when I was at Stanford, like diagnostic criteria. And it was like, what? No, they're never going to test this on like my exam. Like, why would I memorize this stuff? This is like, okay, maybe this will be useful. So I'd make cards on it because I was like, oh, yeah, okay, fine. I guess it'll be useful when I go to clerkships. But I actually found it was shockingly useful for the USMLEs because despite the fact that they don't test it directly, they will never test you on the diagnostic criteria. Like they will never test you on the Tokyo criteria on step 1 or step 2, most likely. But knowing the criteria will actually help because if you look at the vignette, by basically the first sentence you might kind of suspect it, but because you right upper quadrant pain in and of itself and fever is enough that it is suspected diagnosis of for cholecystitis.
Acute. Yeah,
Cool.
absolutely. Yeah, I was even doing questions before with Lyra, and she pointed out that this patient has SIRS, like this patient septic.
Yes.
And, it was just from looking at these values that I've never looked at before. I used to ignore like blood pressure and heart rate. I'm like, it's messed up. We're going to keep moving on. So it's a big difference. I think it's really good.
Yeah, exactly. And if you can say, oh yeah, they meet 2 of the 3, like this would technically be using the Tokyo criteria. This would technically be suspected acute cholecystitis. I think we should do an ultrasound to confirm. Like your attending's jaw will drop. Like.
Yeah, I can't wait. I've seen it too with Virchow's triad. I had this question that was super simple and almost impossible to answer, but just knowing that he was a smoker, I was like, oh, that's like 2 out of 3 criteria right there for Virchow's triad. He might have like a pulmonary embolism, DVT or something. Yeah, that's cool.
Yeah, exactly. Because again, it's just a concept, right? Systemic inflammation, local inflammation, and then imaging. So then, because they're not always going to give you like, oh, high white count, or they're not always going to give you like fever. They're not always going to give you, it might be a high CRP. Who knows? But as long as you can say, oh, okay, there's systemic inflammation, there's local inflammation. So that's suspected cholecystitis. Now, let's just do, now like the imaging. Oh yeah, they're just trying to show that this is definitive diagnosis.
I hope we all get this multiple questions on this on test day.
I know. Yeah, exactly. That's my hope. Yeah, that's my hope. But again, my hope really is that you guys can really see the concepts behind the details. That you're not looking at this as like, oh yeah, fever. Oh yeah, like you can start to abstract away the details and start to see really just like the concepts behind it. That is, I think, one of the really fun aspects of medicine is when you can step back and see the big picture. Lyra says, I thought it was not too much.
Can I ask a question?
Oh, yeah, go ahead, Isaac.
Yeah, this was just another gold lecture, so thank you for that. Could you backtrack a bit to when you were talking about like when an ultrasound would not be effective?
Sure.
I think you were talking about like someone with a gallstone, like why you wouldn't use ultrasound.
Gallstone? No.
I missed that.
Gallstones, you can use ultrasound for gallstones. That's actually good. That's probably like that would be the diagnostic imaging of choice for gallstones. Use ultrasound.
So what was the example you used of when not to use? Oh, pancreatic imaging. Okay, it's full of air. Okay.
Well, it's because the stomach, the intestines are full of air.
Right. Okay.
Air
Okay.
in the stomach
Thank you.
and intestines, right? It's not the stomach in and of itself inherently is bad, or having something in front of it is bad. It's the fact that there's air. Oftentimes there's going to be air in your stomach and air in your intestines. That is bad.
Okay, got it.
Yeah. Air is the enemy of ultrasound. Yeah.
Gotcha.
So that's why, just remember, that's why you always use gel, right? Every time you use gel.
Oh yeah.
Think about it. What can you be, right? They always do the gel. Yeah, my daughter was funny. They had this gel warmer, so it was like nice and warm, and so it wasn't like cold. I was like, oh no, it's gonna be kind of cold. They're like, oh no, we warm it. I was like, oh wow. It's like, why are you tying she's asking all these weird. It's like, why are you tying a towel around my waist? It's like, oh, it's just so it doesn't get the gel in your pants. Why are you doing blah blah blah? What is that?
Dolphins also use sonar, right?
Yeah, exactly. Dolphins.
Okay, cool. It's like little dolphins.
Yeah, exactly. Whales, killer whales. Yeah, my daughter's thing is she loves marine biology, so yeah, we have tons of books. Yeah, so yeah, it's basically bats, whales, sharks don't, but yeah, dolphins. Other questions?
I have a quick question.
Sure.
It pertains to the NBME scores when you enter them in for your progress. There is pretty much, it says a 3-digit score, but if you're doing the shelf assessments,
Oh, shelf NBMEs.
it's only
Use the one that's out of 100. So in other words, it might say like 25 or 28 or something.
yes.
Right? Don't say
Okay,
28.
so-
Say like 89 or whatever it corresponds to.
Okay. So I put because I originally put like the 20s, and then so I should put it to the
Correct.
percentage.
Yeah. Because I don't really know. Like I know that high 20s is good and low 10s is bad, but I don't actually know. I haven't memorized the conversion table. So,
Okay.
Yeah.
Thank you.
Yeah. But great question. Same thing this goes for all of you guys. So when you put in your NBMEs, I look at these. I was just looking at, this is why I knew Devin's NBME score. But when you put it in, convert it to the 3-digit score if it's step 1 or step 2, meaning like don't say like 450, right? You would say like 235, whatever the converted score is. Same thing with the shelf exams. Don't put like 25, right? Put 79 or whatever that corresponds. So the one that's the converted score.
Thank you.
Yeah. Other questions? All right, guys, thank you very much. This was a pleasure. And we've got plenty more like this where we are going to be, again, helping to apply concepts and helping you to see past the details. So I look forward to...
Doc, very quick. What are you referring to when you say shelf exams? I know what NBMEs are.
Are you studying for step 2 or are you in clerkships?
Oh, no.
Then don't work on it. All right, guys. Thank you. All right, take care. If this clicked for GI, the next video shows you how to think this way across the entire exam. You'll learn the framework that prevents missing questions you already know and how to guarantee 90+% on every topic. Click here to watch how to virtually guarantee a 260+ in step 2 and see how students went from failing to scoring in the top 10, 5, or even 1%.